Hello everybody, and welcome to today's webinar, which is a second webinar in the series. So today we'll be discussing about the diagnosis and assessment of asthma in adults, young people, and children. And this series has brought to you in collaboration with Asthma and Lung UK. So my name is Preeti Minhas. I'm the Director of Clinical Development, and I'll be joined today with Dr. Andy Whittamore from Asthma and Lung UK. He's the clinical lead for the organisation. Next slide, please. So that's a little bit about us. And before we begin into today's content, just a little bit of housekeeping. So you'll see at the top there is a Q&A channel. That's where you can put your questions, and we will try and get to it as quickly as we can. Andy will be taking us through today's contents, and we'll leave around 10 to 15 minutes towards the end of the presentation where we'll be asking Andy and putting you on the hot seat for some of these questions. But equally, you've already submitted some of the questions as part of your pre-registration. So again, we will endeavour to get to all of the questions as quickly as we can, but it will be towards the end of today's presentation. Next slide, please. So in terms of just a little bit about who we are, so Education for Health is a charity, and our predominant aim is to support patients with long-term conditions. And we do that through developing the knowledge and know-how of our healthcare professionals. We have two arms to the organisation, or two main arms, as I normally like to say. So one arm of the organisation is where we deliver academically accredited courses at degree, diploma and master's level, in collaboration with the University of Hertfordshire, and we also deliver short, sharp pieces of bite-sized learning through our CPD accredited courses. We've also launched an Ursula Gallagher bursary, and today's sessions and the remaining part of the webinars for this series has been brought to you through the Ursula Gallagher bursary that we set up recently. Next slide, please. To ensure that our courses where they need to be to support our healthcare professionals, we have a clinical practice advisory group who have made up of some of the healthcare professionals you can see on the screen there. As well as to continuously quality assure our material, we also have a number of committees in line with those therapeutic areas. So we have an asthma committee through to other long-term condition committees. And these are really there to ensure that our courses are there to support you on the front line. So that's a little bit about us at Education for Health. And as I said, I'm delighted to be joined today by Andy. So Andy, take it away.
Thank you, Preeti. And thank you to Education for Health for allowing us to come and talk at this meeting. I'm Andy Whittamore. I'm a GP based down in Portsmouth. Been a GP for about 20 years now, which is a quite scary fact. And over the years, I've had a lot of different roles, but for the last 8 years, working with Asthma UK and then Asthma and Lung UK as they are now, working to support the organisation in whatever way they need, from developing stuff for the website, supporting their helpline team, working with the policy team and media team as well, and anything that just makes sure that the organisation remains current and accurate. Now, this guideline we've been waiting for it for a long time. Lots of reasons for that. Obviously, we've got NICE working together with BCS and SIGN, which means that the different approaches to guidelines have had to come together. We've been particularly keen for this guideline to be produced because there's been a lot of evidence produced worldwide to support asthma diagnosis and management, and actually bringing the UK back in line with the rest of the world was something we really wanted to do, especially with the GINA guidelines around treatment. And we wanted to make sure that in turn that made sure that actually as clinicians we are all giving our patients the best that we can, whether that's primary care, secondary care, specialist asthma clinics and the hospital. We should all be doing exactly the same thing. And this guideline is specifically focused on diagnosis, monitoring and treatment, and today we're really just talking about diagnosis, with future sessions to talk about the other aspects. But actually what NICE have done is put this in the centre of a whole suite of resources which are worth having a look at. They've refreshed some of the stuff on acute asthma, on severe asthma. the nice CKS pages are really useful in terms of talking people through how to manage certain scenarios as well. So as well as coming to these talks and looking at the slides and getting into practice, have a look at some of those other resources as well. One of the things that we all know is that asthma isn't very easy to diagnose. It's a very common condition with very common symptoms, but actually we need to simplify the diagnosis. And this guideline has really done that really well. And I'll talk a little bit about that in a minute. The other thing this guideline has done is focused on, I'd say, treatment and moving towards air and MART therapies. And future sessions we'll go into that in a lot more detail. And definitely worth reading through the guideline in your spare time, if you have any, to sort of go through some of the other things that it covers in terms of greater clarity on who should be doing what and when, and actually making sure that every clinician who's at every part of the patient pathway is doing the right things. So it's not, if you work in A&E or an urgent care centre, 111 999, you should all be aware of what treatments and pathways patients should be on. So it's really important that all groups are aware of this guideline. So moving directly on to diagnosis, one thing this guideline does really, really well is simplifies the approach towards it. One thing that I've had difficulty with previous guidelines is when they've talked about all the importance of taking a history, decent examination, and then they produce an algorithm. And actually every clinician prints up the algorithm and doesn't really focus on the fact that history and examination are central to any diagnosis. This guideline takes it back to that really clearly. And there's lots of sort of reasons why we do that, because what that does firstly is it means that actually we've got an understanding of the patient's symptoms, what triggers them off, and what is making us think they might have asthma. Secondly, by having a really good clinical history in the background, it means that the testing for asthma can actually be made easier. Previous guidelines have said we needed 2 tests to diagnose asthma, usually a test of inflammation and a test of measuring obstruction. But what this does is it takes the fact that there are no perfect tests for asthma and upscales them because we've got a really good clinical history. So, for example, with and we'll come on to eosinophils and FeNO in a bit, slightly lower levels of FeNO and eosinophil levels can suggest asthma. But actually, if you've got somebody where you really think they've got asthma, and you've also got a high level for FeNO or eosinophil count, then you can have even greater certainty that that diagnosis is asthma. And when you look through all the sort of data tables around how good or how bad tests are at ruling in or ruling out asthma, there is no perfect test. But when you start setting higher thresholds, you can be more certain that that test is truly confirming somebody's got asthma, especially if they've got a good clinical history. On the other side of that, though, what this guideline does is it does go against a lot of other diseases that we used to see and diagnose. A negative test does not exclude asthma. And actually what we need people to do is work through a series of tests until we get a positive test that confirms their diagnosis. Whereas in other diseases, we get a negative test, we say they haven't got that condition. Tests for asthma are not that good. They're good at telling you somebody's got something, but they don't tell you that they haven't got asthma. And that's because asthma is a variable condition, and there's lots of different types of asthma as well. Another key aspect of this guideline, and the guideline committee really listened to some of the feedback that organisations like Asthma and Lung UK and PCRS put back to the draft guideline when it came out, is because asthma does come and go and it takes time to get the test done and to prove the diagnosis. It's really important that we put a read code on the note such as suspected asthma. And by doing that, it means that patient can be tracked over time, especially with children where they might be several years before they can properly do the tests to confirm their diagnosis. So I think that's a really important point. We take a really clear history and examination. We think somebody's got asthma. We diagnose them as suspected asthma until we can prove they've got it or not. And because only one test is needed on the back of that good history and examination, it means that we're not waiting for different tests and different combinations of results to get there. We need to sort of work through the tests until we can actually confirm there's a positive test that confirms our theory that somebody's got asthma. big thing this guideline does is looking at how effective different tests are. It wants us to start by looking for inflammation. And most people with asthma have got an inflammatory type of asthma, especially when you're looking at children, but also adults as well. And actually, measures of inflammation are much more effective than other measures, picking up, for example, obstruction. So what they want us to do first is to measure FeNO or blood eosinophil levels. And FeNO and blood eosinophil levels are a sort of a marker or a proxy marker of the type 2 inflammation that causes many people's asthma symptoms. So if those levels are raised, we can be very suspicious they've got asthma. But in somebody who we think has got asthma and they've got a very high level, so in FeNO a level of over 50 parts per billion, or eosinophil above the local range, but in practice above 0.5, then we should be thinking that person has definitely got asthma and starting to sort of diagnose them. And if those tests are negative, they don't prove asthma in the person that we think has got asthma, then we should automatically move on to the second lot of testing, which is looking for obstruction. So by doing this, if they haven't got an inflammatory type of asthma, then we're looking for obstruction, as that's their phenotype of what's going on. But also, if we just happen to catch them when their levels are low, because these things are all variable, then there's a chance that we can pick it up with that second test as well. There are lots of very clear parts of this guideline, and if those tests aren't available or they come back negative in somebody which we are convinced they've got asthma, then we need to be getting secondary care to also perform tests, and that might well be bronchial hyperreactivity. And another important part of this guideline, which I and I know lots of other sort of clinicians are pleased about, is actually we can start thinking about the diagnosis of asthma when that person presents acutely for the first time. The number of times in our acute clinics, or even when I'm speaking to people in triage on the telephone, who I suspect they've got asthma because of a strong family history, because they're wheezing, their symptoms come on with typical allergens like pollen, or with sort of viral illness, and I think they've got asthma, we need to be sort of thinking about proving the diagnosis at that point. And again, this guideline helps us with a framework to do that. So as I said, clinical history is key to all of this. We need to be not just asking about these things, but recording them in the notes, because when the patient comes back to see somebody else, or it might be that we can't prove asthma and that there's somewhere further down the line they come back and present again, we can look back and comment on exactly what that person's pattern of symptoms and triggers are. And we need to look at when those symptoms are happening. Are they worse at certain times of day? Is it seasonal? Are there certain triggers that set them off? Is it related to times when there's poor air quality, they're exercising? Could it be hormonal, work-related, stress-related? There's lots of things we need to be asking about to try and build up a picture of what's going on with that patient in front of us. And every individual patient is individual, so it's really worth taking a big history and seeing how they sort of fit into an asthma diagnosis. Other things that are important are, have they got a family history of asthma? Did somebody think they had asthma or give them inhalers when they were younger? Have they got history of other atopic conditions such as allergic rhinitis, hay fever? And those sorts of things can, and dermatitis, and sort of that sort of thing can help to feed into that bigger picture of a jigsaw that we try and sort of come up with people when coming up with a diagnosis. And another thing we need to be doing is not just looking about what could be causing their symptoms, putting them in a box that we think they've got asthma, but is there actually something else going on that could be causing their symptoms as well? So symptoms such as coughing, breathlessness, wheeze can happen with lots of different conditions. And just because asthma is very common, it does not mean that person has asthma as a cause of their symptoms. So asking about postnasal drip, sinusitis, no symptoms, gastric reflux, and in any other cases, you might be sort of inquiring about symptoms that point more to the heart or COPD or mental health. So there's lots of different things there. And actually, if you look at the NICE website for the asthma diagnosis, there is actually a link to various questions and features you can ask about which point to different conditions. And that's quite a useful sort of part of this. So it's really important to document all these things so people can understand your thinking. And actually, when over time you're sort of getting all the tests done and putting that big jigsaw together, you can actually sort of piece it together better rather than just recalling what patients said going back. And of course, recoding suspected asthma at that point before you start objective testing. And examination is important as well. If you're trained to do examination, you're confident doing that, then brilliant. If not, then make sure somebody else in the team has been able to do that for you. I always encourage our team to try and document everything that they notice, whether there is a wheeze or not, because that can help going forwards. Not every person with asthma will wheeze, but actually it's an important sort of marker for them. And then looking for evidence of other diagnoses as well. So have they got a runny nose? Have they got sinus symptoms? Have they got crackles at the base of their lungs? Have they got swollen ankles? All sorts of other things that can not just tell you whether somebody might have asthma, but have they got something else as well? And as I said, the acute presentation is a really important point. A lot of the tests for asthma are more likely to be positive when somebody is symptomatic. So actually, this guideline really strongly encourages us to start doing tests when they're presenting with symptoms. However, it also tends to balance that if they are unwell or highly symptomatic, then treating them immediately is important. So whether that's oral steroids, whether it's nebulizer, those sorts of things, do not forget and neglect those side of things. The guideline clearly says that consider doing eosinophil count, FeNO, spirometry, and encourages peak flow at this point. So when somebody is presenting acutely, having peak flow or spirometry levels where you can show that there is airflow obstruction, which is relieved by bronchodilator medication. That can be a really crucial and quick way of getting somebody diagnosed. Thing just to point out on that is that FeNO levels will go up when somebody is acutely unwell because of hay fever symptoms or allergic symptoms, and will also go up if they've got an acute viral illness in their airways as well. So those things will need to be sort of bear in mind rather than just doing it blanket on everybody who presents acutely. If for whatever reason you've not been able to do the test acutely, then once the person's symptoms are more closely controlled, then starting the diagnosis pathway. So when you look at adults and children over the age of 16, then what it's sort of suggesting we do is we start with a test for inflammation. The evidence they had and used as part of this guideline showed that blood eosinophil counts above the local laboratory range, but in practice that's probably above 0.5, and FeNO levels above 50, which is higher than we've previously used for diagnosing asthma, can be used to try and come up with a diagnosis at that point in someone who's got a very clear history of asthma. If they've got a negative test at that point and you still think it's asthma, then moving on to the next test, which they suggest we should be doing spirometry or bronchodilator reversibility as the gold standard test for picking up people with airflow obstruction. But if for any reason there's long waits for spirometry or it's not available in your area and we're still sort of fighting to try and get that to happen, then using a peak flow diary for 2 weeks is a valid way of doing that. And if those tests are still negative and somebody who you think has got asthma, then referral is the right thing to be doing. There's no place for trial or treatment in this guideline. What we'll try and do is share these slides afterwards with everybody so they can sort of keep up with it and sort of read it at their leisure. But actually, this slide repeats a lot of what I already said. I think the thing just to bear in mind is that there are lots of other causes of raised eosinophil count and FeNO, but the idea is that in this guideline, we're talking about people who we think has got asthma. We've taken a good clinical history. They've got risk factors for having asthma. They've got symptoms and triggers which make it likely as well. But just to bear in mind that FeNO also goes up in people who've got allergic rhinosinusitis, people who have got acute viral illness going on in their airways as well. Eosinophil counts can go up in people who've got parasite infections. So there's lots of other reasons why these can happen, and it's important to sort of just take care of that when you're taking a history. But the important thing is we're talking about people here who we already have taken a history from and we think they've got asthma. Now, a couple of years ago, I was closely involved with the national rollout of FeNO, and we got it was a really successful rollout, apart from getting it fully funded by the NHS. That is hopefully going to come now. The NICE guidelines are backing it, and we'll see where that sort of appears in the new GP contract for NHS England, certainly next year. FeNO levels go up when there's raised eosinophil levels in the airways. So it's a good measure of airway inflammation. We also use FeNO to try and identify when people have got untreated inflammation. So actually, if somebody's already got asthma, then it can be used to identify whether they're taking enough of their treatment, whether they're taking it correctly, and whether they might just need a higher dose of their medication. Having a raised FeNO level is a really good indicator that somebody would benefit from inhaled corticosteroids. So very useful in sort of steering treatment. And the guideline, again, uses FeNO in the monitoring as well. So lots of evidence behind FeNO. So we know that FeNO is an effective way of measuring the type 2 inflammation in the airways and telling us whether somebody's got untreated inflammation. And actually, there is lots of evidence about reducing contacts with the NHS, exacerbations, admissions to hospital, and therefore FeNO is a cost-effective tool for people with asthma and suspected asthma. I think it's also an important way of helping to educate patients. We know that with diabetes and blood pressure, people like to know their number. They like to know how well their disease is controlled. People aren't usually that worried about peak flow levels, spirometry levels, but actually FeNO really does engage people. And the number of patients when we were using FeNO who, while they're waiting for the result, would then just slyly admit that they hadn't been using their steroid inhaler properly or regularly, and that was really useful, just getting that conversation going. And then when their levels were high, they knew that there was a good reason there for taking that inhaler. If you're not familiar with FeNO, we put together a toolkit for practices and healthcare professionals a couple of years ago. Everything on there is still valid. We're just updating the education package, which is free, just so that it does reflect these new NICE guidelines. Lots of things in there about how to communicate with patients. There's AccuRx links. There's templates that are used in System 1 and EMIS. There's information about what to send to patients to prepare for the test, and even things like business cases as well. So if you're trying to argue with your practice or your local area as to whether you need FeNO at practice or PCN or some other level, then all the tools there for putting together a business case are there. We're still waiting for the NHS itself to catch up, because once we can get funding stream built in, then that means hopefully FeNO will be available routinely for everybody with asthma. If we do not manage to prove asthma with either eosinophils or FeNO test, then the advice is to move on to bronchodilator reversibility. And actually having good standard spirometry with reversibility done to ARTP level, although actually we do know that some areas are not following ARTP. They've got their own high local standards that are being followed. Then actually, if you meet those standards, then you can be pretty sure that a positive test is diagnostic of asthma in somebody with a clear history. So really important that spirometry is available locally. And again, there's lots of pushing from NHS England and organisations such as Asthma Lung UK to make sure that ICBs are making sure there is enough spirometry available around. The guidelines are really clear in saying that if the FEV1 increases by 12% and 200 mils or more, then that is diagnostic of asthma. So really important that those tests are done, and that can help to sort of discriminate between asthma and COPD, for example. When you're interpreting spirometry, important you've got the right training to be doing that effectively. Lots of changes over the last sort of few years about how we interpret spirometry, and moving away from absolute levels to Z scores, which tells us how likely it is that result is valid for somebody's age and ethnicity and other demographic factors. But really important that actually, if you've got that qualification, then you're using it effectively to support your team and make sure that your patient's got an accurate diagnosis. Peak flow wasn't initially included much in the draft guidelines, but actually once it was fed back that actually spirometry wasn't readily available at the moment, the guideline committee considered that actually having peak flow variability as part of the guideline was actually important, but only if spirometry is not available or there are significant delays in your patient getting it. And what is recommended is what we've been doing with spirometry, with peak flow for a long time, which is twice daily measurements over 2 weeks and then measuring the amplitude percentage mean. So what we generally should be doing is telling patients to take best of 3 readings morning and evening at the same time each day, 2 weeks, plotting them on a chart or at least jotting down the readings and then submitting them so that we can sort of translate them into what that actually means. Lung UK have recently incorporated a peak flow variability calculator onto the website, so feel free to have a look at this and some of the other resources we've got there to support you. And from many people who've been feeding back, this is a game changer, saving hours of effort and lots of calculator battery as well. However, if there's no measures of inflammation and obstruction to prove the asthma in the person you think has got asthma, then it's recommended that we refer them to specialist services so they can have a bronchial challenge test. Many places have got this, but not everywhere. And if we were to refer everybody, then services would be overwhelmed. But it's important to understand the concept that in people who we think we've got asthma, we do need that positive test, whether it's FeNO, whether it's eosinophils, bronchial challenge test to actually diagnose somebody with asthma. Again, for more for your information later, here's a summary of the algorithm for diagnosing adults with asthma. Slightly different in children, although the same sort of basic rules sort of apply. Firstly, we're trying to test for inflammation. And it was felt that actually doing blood eosinophil levels on children wasn't appropriate in every case. So actually starting with FeNO test as a first line for children with asthma. Children are more likely to have allergic asthma. So actually having a test for inflammation makes a lot of sense before testing with spirometry or peak flow. And the levels for diagnosing in children are slightly lower as well, so 35 parts per billion, as opposed to the 50 that we had in adults. And that's because there is clearer evidence around this in children, and also we've got greater certainty about the results in this age group. So if somebody has a positive FeNO test and in somebody you think has got asthma, we can diagnose asthma at that point. If it's negative, we should be again moving on to a test for obstruction and reversibility. And again, it's recommending spirometry with reversibility at that point. Very similar to adults, but really important that people who are doing this test and interpreting it have got the correct training and experience to do that. If spirometry for children is delayed, or again, you've not got it available in your area, then it would be very reasonable to encourage a peak flow diary. Exactly the same as with adults, although a lot more training is needed. But actually, we find that children are quite often better at following those instructions and actually bringing back a test. Maybe because as well as the children, that there's parents to support them as well. Not in every case, but certainly that makes it much more likely than some of the adults we see. And if that test is still negative, then they do encourage checking for different allergic triggers for asthma. So firstly, a positive skin prick test for house dust mite can diagnose asthma. We don't have much of that available in primary care, but other settings might have that. And if that isn't available, I'm doing a blood test for eosinophil levels and IgE, just basic IgE. If both those things are raised, again, that's a positive test for asthma. If we're thinking that somebody's got asthma and again, all these tests are either not available or they've ended up negative, then we should again be referring to secondary care where they'll reassess them, they'll go through whatever test they've got available, and that might include bronchial challenge testing. In all age groups, even in under 5s, we should be sort of read coding as suspected asthma. Again, that gives us a chance to follow them up, especially in under 5s who quite often or usually can't do the test that we're wanting to do. In the under fives, this is the only group where the guideline does encourage us to do a trial of treatment. So 8 to 12 weeks of low dose, pediatric low dose corticosteroids. And again, the guideline has a link to a chart telling you what doses that sort of equates to. And then monitoring that patient regularly. If their symptoms are resolving, then stopping it until they either get symptoms come back or they have an acute episode. And again, you're restarting it at that point. If they're still symptomatic, even with that pediatric low dose inhaled steroid, then again, checking for obvious things like their inhaler technique. Are they taking their inhaler regularly? Are there things around them that are really triggering off their symptoms and stopping that inhaler working? So that could be exposure to mold, smoking, indoor pollution, poorly heated housing. And also at these stages, we should be thinking about, have we got the suspected diagnosis wrong? If you've got no way of, if you really don't know why that person is still getting symptoms, then they should be referred at that point. Once they get to about 5, we should be able to do testing on them. In my experience, pheno is very easy from somebody 7 or 8, but we did have quite a few patients at 5 who could do it with training. But until the point where they're able to do those tests, we should be following them up every 6 to 12 months, depending on their symptoms and medication they're taking. This guideline is very strong in actually telling us exactly when we should be referring somebody to secondary care. So if they've had an admission to hospital, they've had 2 visits to A&E or to other acute centres within 12 months, then we should be referring them to hospital, because actually it's more likely they've got asthma or they've got something severe with their lungs that they need looking into. So as I said, pheno is a bit more acceptable in children than a blood eosinophil level. And we do feel that 35 parts per billion is very specific for asthma in this age. Because we haven't got the tests everywhere, then actually we might be moving on to other tests such as spirometry, peak flow, and so on. But actually, I say in my experience, many children where pheno is available can do these tests. Again, looking at spirometry in children. So if pheno is not available, then moving straight onto that. And again, you're looking for that sort of 12% from baseline in this age group. Similar to adults, if spirometry is not available, then actually peak flow is a valid way of diagnosing asthma. And actually using that very similar to as we do in adults, best of 3 readings, morning and evening, same time every day, and doing that for 2 weeks. And again, using the peak flow calculator on the Asthma Lung UK website. And again, we're looking at the variability expressed as the amplitude percentage mean. So again, the calculator will do all this for you, but actually if you're basically looking at an average of 20% from morning to evening readings over that 2 weeks. And again, for your records there's a summary of the guideline in children. Definitely worth working through the guideline and say having a read of it. There's a reasonably short section on occupational asthma, and it suggests that we consider firstly whether they've got occupational asthma or occupation aggravating their asthma in anybody who's got new onset asthma as an adult, people who've got poorly controlled asthma, and if they've got a reappearance of childhood asthma. So there must be something in their workplace that might be setting them off. And specific questions to ask are whether they are better or worse on days away from work. So whether that's if they don't work weekends, their symptoms are better then, or when they're on holiday or on leave for any reason. And that can sort of give a really good idea as to whether something in their work is aggravating their lungs. Really important, again, to document answers. And everybody who you think has got suspected occupational asthma should be referred to a specialist, and they will arrange the relevant tests to follow them up and get them on the right treatment and management plan for them and their employer as well. So it's a little bit of a whistle-stop tour, but hopefully I've given you some good flavours of what this guideline is trying to do. So I think just to highlight, the most important things are taking a really clear history, having suspected asthma recoded in the notes, and then working through a series of tests until you get a test to confirm that it's asthma. And if you don't get a test that confirm it's asthma, then we should be referring onto specialist care for a review at that point. So thank you. And I think looking at Preeti's face, we've got 100 questions coming.
Yeah, no, thank you, Andy. That was really helpful. So can I ask everybody, just to reiterate, I won't be able to take questions due to the numbers of attendees today by you raising your hand. So if you do have questions, please can I ask you to put them in the Q&A function, and we will endeavour to get to them. But some of your questions, for those of you that registered questions before attending, so if we proceed with them. So the first question in today is, as a GP, I don't have access to pheno or spirometry. How do we approach patient care and minimise diagnostic uncertainty? So I think you discussed some of that, but it'd be great to hear your thoughts.
Yeah, so we've touched on that a little bit already, but the problem is that the GP contract at the moment doesn't fund us directly to do pheno or spirometry. And it's a complex issue that NHS England and the other NHS bodies are trying to sort of piece together at the moment. There is a big push to ICBs and other organisations to restart spirometry to make sure there's enough capacity for people. And Asthma Lung UK are working very hard with ICBs and NHS England to make sure that is happening. But it's not an easy problem. We need to make sure the equipment is there. We need to make sure that the training is there and people are up to the right standard. We need to make sure that funding is there. And then we need to make sure that it's done well and in the right way for people. So with an update to the GP contract next year, hopefully that will include some funding for pheno and spirometry. Hopefully there will be some updates to QoF that encourage us to do the right test for our patients. And we need very clear instructions for ICBs and other provider bodies to try and make sure that the right tests are available. If these tests aren't available, then as you saw, there's two different tracks. So firstly, in adults, eosinophils was a very valid first test for people with suspected asthma. So you don't need pheno or spirometry to diagnose asthma if they've got high eosinophil count. The difficulty comes if their levels aren't significantly raised, and then you'd move on to the next test, which in adults would be peak flow. So actually peak flow is a valid way of diagnosing asthma in adults there. With children, pheno was the first line test. So if that's not available and spirometry is not available, then again, peak flow is valid, but some children do find it much more difficult to do. And you could do a blood test for eosinophils and IgE, or skin prick test if you've got those things available. What we don't want to do is overwhelm secondary care, refer everybody with suspected asthma to paediatricians or to asthma clinics. But there are certainly some things in there that we can be doing. So I suppose to answer the question, hopefully things will change in the next year. So actually we have got the resources throughout the system, definitely in primary care, to deliver pheno for everybody and spirometry for those who need it. But actually we've got peak flows, eosinophil levels for the right patients that can help us in patients with a clear history to come up with a good diagnosis.
Great, thank you. So again, a lot of questions about access to pheno again. So I'm going to take some of these questions just to make sure everybody has got an opportunity to have their question answered. The guidelines discuss the various object testing with regards to pheno. Can asthma be diagnosed using only spirometry reversibility? And I know you've touched on that throughout your presentation, but just to get some clarity for learners today.
Yeah, so if we look at the last NICE guidelines, they wanted us to do two tests, ideally a test for obstruction and ideally a test for inflammation as well. Because of the way this guideline has been structured, they're presuming that we're taking really good clear history so that we know that we suspect asthma in that person. And if that's the case, and you set a high enough level for pheno or eosinophil count, you can diagnose asthma. So one test is needed. If either of those tests is negative, then we'd move on to spirometry with bronchodilator reversibility. And if that test is positive, you can diagnose asthma. So I suppose going back to the question, with a good clinical history, you suspect it's asthma, you only need one test. Spirometry and bronchodilator reversibility wouldn't be the first choice of test, depending on what's available, but it would be a valid way of diagnosing somebody. You don't need any other test to confirm it.
Great. And I think just linking to that, then, there is a couple of questions about the role of eosinophils, of which we've got one. Is one blood test with raised eosinophils sufficient to make a diagnosis, or should it be done over a period of time?
This is one area where the guideline wasn't particularly clear. Um, my personal view on this is if somebody is presenting with asthma-like symptoms and your history makes you think they've got asthma, and they've got high eosinophil counts at around the same time, so maybe within a month, maybe within 2 months, then I think you can confidently diagnose asthma based on that. I know people working in severe asthma clinics, when they're wondering whether somebody has got severe asthma, will look back at a pattern of eosinophils over many years. But I think when we're looking purely at the diagnosis side of things, I think we need to make sure that we're tying up an eosinophil count that's raised around the time that somebody has got asthma symptoms. And of course, ruling out other causes of raised eosinophils. So you're asking people about whether they've got any parasite infections or significant fungal infections. There are some autoimmune conditions that can cause raised eosinophils. But again, rather than worrying too much about all the different things that can cause that, we're talking about people who have got a history suggested of asthma.
Great, thank you. So just to run through, we talked a little bit about, and you discussed this at the beginning of the presentation, was around, diagnosing an asthma in adulthood can mimic other symptoms and disease states. I guess, are there any hints and tips from when you're delivering your consultations that you undertake to make sure that you ensure an accurate diagnosis in asthma?
I think first thing, just to reiterate, have a look at the NICE guideline itself. Near the bit on assessing people with suspected asthma, there are a couple of links to other conditions that can mimic asthma in adults and children. And there's some lists there of things that we all know about, but some key questions that we can ask at that point. The other thing that's quite useful is the NICE clinical knowledge summary, CKS, which they sort of take the guideline and make it very practical. So actually you can work through, there's some examples on there on how you might structure an examination and a clinical history to work out whether somebody's got asthma. And again, that they're really good learning tools to try and sort of embed this guideline into how you work and how you practice. My own personal approach on this is asthma symptoms are very common. Coughing, breathlessness, and even wheeze can be mimicked by so many other different conditions. And it can be really hard to identify asthma in people who come with those symptoms. Certainly over this winter, the number of telephone calls and people I've seen who have presented coughing and wheezing and then trying to tease out whether they might have asthma or not, it's quite hard to do sometimes. And then I actually take that a step further. Even in people where we know they've got asthma, we need to be questioning whether the symptoms they've got are definitely due to asthma, rather than putting them on oral steroids, change their inhalers, but actually just working through whether we truly believe their current symptoms are due to asthma or not. So when I'm taking a history, I look for people's risks of having asthma. Did they have asthma as a child? Did they have inhalers as a child? Do they have a family history of asthma? Have they got personal or a family history of atopy? So hay fever, rhinitis, eczema. Are they in a job, or have they got hobbies that have got some sort of trigger that might actually set off asthma-like symptoms as well? And on top of that, I always ask them about the pattern. So when do they get those symptoms? What makes them better? What makes them worse? Are there certainly things that could, again, just add to that picture that this is due to a reversible allergic type trigger or something else like that?
Great.
As well as the sorry, just
No, no,
taking
no.
breath for a minute. As well as that, I then sort of start looking at some of the other things that might mimic asthma. So have they got nose symptoms? Runny nose, sneezing, blocked nose? Not just because that could be a trigger for asthma symptoms, but it could actually be a trigger for the symptoms that make it look like asthma. Asking about postnasal drip, do they feel things going down their throat? Do they get acid reflux? Do they feel like acid's coming up and irritating them at the back of their throat? And of course, if they're older, you might be asking about heart symptoms, so breathlessness lying down, swelling of ankles, palpitations, and again, there's lots of different things that you can sort of work through there. Next thing I'll do is read code the suspected asthma, Because at the moment, we're not doing those tests acutely. And those tests that we would be doing, it might be starting a peak flow diary at that point. And actually, for when that patient comes back, I've documented all the bits that I think could make it asthma, all the things I think could give us a different diagnosis. And the suspected asthma allows me to easily follow those patients up. And then once I've got those objective tests, we can start to sort of piece together the jigsaw. And actually, people hopefully can follow my thinking as well.
Thank you so much. And I think that's something we definitely talk about in our, in our courses when we deliver our workshops on our academic courses. It's that history taking is the cornerstone of any diagnosis. And, certainly, a model that we frequently use is the ICE model, which is the ideas, concerns and expectation model. So that's really useful when undertaking a consultation. So there has been a question asked in the chat, which is how would you differentiate occupational asthma to occupational COPD?
That's slightly more difficult. I mean, occupational asthma, because asthma is a condition that comes and goes, it's variable, and actually it's that pattern that allows you to sort of piece together what their triggers are and whether that could be occupational or not. So again, I think we touched on that in the talk, that if people are getting more symptoms when they're at work, but less symptoms when they're away from work or on holiday, then you can start to piece together whether that person's got occupational asthma and refer them for specialist assessment. Occupational COPD is a little bit more difficult, and actually because that takes more time to come on, it happens over a longer duration. But again, if you're thinking that somebody's occupation is affecting their lungs, then actually referring early is really important.
Great, thank you. There is a question in the chat around allocated funding for secondary services. So I think, Andy, you talked a little bit about, we have got an update, for instance, in primary care. I think, overall we have a new government, and I think, there's certain focuses from NHSE. So it's probably not a question we can answer today, but certainly I'd say kind of look out for updates around funding. So we've got a couple of minutes just around some of the other questions that we've had, and I know you may have answered some of these already in the presentation, but again, just for clarity, can you just talk a little bit more about the role of peak flow in diagnosis and monitoring and management of asthma, if that's okay?
So from shifting from the draft guideline to the final published guideline, peak flow appeared a little bit more towards the end. There were several places where peak flow is mentioned. So firstly, when patients are presenting for the first time acutely, then actually there is a place for using peak flow to diagnose asthma at that point. And it actually says if you can see evidence of bronchodilator reversibility in somebody symptomatic with asthma-like symptoms with peak flow, then you can diagnose asthma at that point. I think using peak flows in patients who are presenting with acute symptoms is essential. Because if you look at the old NICE and BTS sign guidelines for people with acute asthma, then actually we need to know how severe their symptoms are to know what treatment to give them. So in that case, we need to have a peak flow as well as heart rate and all the other things to actually know what sort of treatment and escalation of care they need. So actually peak flow, I think, is crucial to the acute management of asthma. Where this guideline differs slightly from that is it says that patients shouldn't routinely have a peak flow as part of the monitoring process. And I agree with that in principle, in that we don't use peak flow to identify whether people need escalations of treatment in a routine review. But as I said, when they present acutely, it tells how severe their condition is, so we know what we're doing with them. But actually, if we're seeing them when they're well at a routine review, having a peak flow reading at that point gives us a baseline to compare to when they present acutely. So I think there is a place for doing peak flow, but it isn't an essential part of monitoring. In some patients, patients like doing peak flows in some cases. Some people, it's really important that it's part of their self-management plan. And if it is part of their self-management plan, then you should be doing peak flows in their routine reviews. But again, I come back to the fact that when patients present acutely, we need something to compare to. So I would always do a peak flow routinely. You're on mute, Preeti.
Schoolgirl error. So I think we've actually covered a lot of the questions today in regards to access to pheno and spirometry, and certainly in the resource we presented you with earlier, there is details in there, particular within the toolkit, the pheno toolkit. There's lots of resources there that can support you in terms of, business cases, but equally other resources around upskilling yourself on pheno as well, which I think, Andy, you said is currently being updated to reflect the new guidelines. So it's really important that you do take some time to have a look at the resources. Equally, again, on Asthma and Lung UK, the peak flow calculator, as you alluded to, Andy, in your presentation, there's some great resources there to support you. So we have actually gone through all of the questions today, which is great. I really wanted to thank you all for taking the time to listen and register to this webinar. We do have another set of webinars coming through, and they will be announced shortly in the next coming days. So I know there's going to be topics around, there's certainly questions around air and march therapy, and certainly the forthcoming webinars that we will be hosting will cover some of those questions around the pharmacological interventions that are now showing within the new guidelines. So it's really important that please do keep your eye out, and we'll also be looking at how we can empower our patients to help them self-care with their asthma. So again, lots of webinars coming up, so please do keep your eyes peeled for them. Andy alluded to spirometry as well. So again, at Education for Health, we have a number of courses for you to undertake. So we have a huge portfolio around the spirometry training. So again, please do have a look for those as well. And further details are available on our website at www.educationforhealth.org. In terms of today's slides, we will be uploading them onto our website, and we will be hosting some fact sheets that you can take away with you for some of the questions that have been raised today, but also as part of the pre-registration for this webinar. So again, they'll all be available on our website once the webinar series has been complete. So again, please do keep your eyes peeled for those, and you can do that through registering for our newsletters as well on our website. So that leaves me a massive thank you to you all for coming today. I know how busy it is in practice, and thank you so much, Andy, for taking us through the diagnosis and assessment, and we hope to see you soon. Thank you for joining us.